Hi everyone, so this is part 2 of interpreting imaging, and today we are going to discuss some of the basic interpretation of the chest x-rays. So here are two chest x-rays that are normal. This is of a male and this is of a female. So we will discuss what some of the things are. So here you can see the trachea. Here are some of the spinous processes. Then this trachea here divides into two. This is the carina. Then it is the right main bronchi and the left main bronchi. Then there are right and left hilar structures. Then there is a right horizontal fissure. It is very subtle and it is very difficult to see, but it can be seen with, experience. Then there is the right cardiac border of the heart. This is the right atrium. Then this is the left cardiac border that is made by the left ventricle. This is the aortic knuckle, and this is descending aorta. This. Then there is the right paratracheal lines where just give me 1 second. This one. And then there are right and left hemidiaphragms. This is the right one and this is the left one. See how smooth they are. This is the right costophrenic angle and this is the left costophrenic angle, and here is the gastric bubble. Here you can see that this is some breast tissue that outlines the fat that outlines here, so it can be a little denser. So, when interpreting a chest x-ray, we use the ABCDEFGHI approach. So, we see the assessment, we see the airway, and we assess the quality of the film. Here you can see that the quality of the film is really good. The airway is intact. There is no foreign body seen. We see the bones. So, the bones include the ribs, the clavicle, the head of humerus, the scapula, and the vertebrae, the spinous processes. Then these are the bodies of the vertebrae. Then there is cardiac shadow. We see if there is any cardiomegaly, if there is any abnormality seen. Then there is a diaphragm. We see if this diaphragm is smooth, if it is normal in shape, if the difference between right and left side of the diaphragm is abnormal. Then we have any effusion or extrathoracic soft tissue issue. Effusion can be seen here at the costophrenic angles. The extrathoracic soft tissues can be seen at the shoulder, the neck, wherever parts are visible, the abdomen. Then there is any foreign body that can be in the trachea, in the lung, anything, any fissure, any issues of the field. We will discuss all that in further discussion. We see if we can see the gastric bubble. We see if the great vessels are doing okay, the aortic knuckle, the descending aorta and all. We see the hilar if they are normal in shape. We see the mediastinum. We see what the overall impression of the chest x-ray is. So here we can see the bony thorax. There is the right and left clavicles. There are different ribs. This is a posterior anterior chest x-ray film. So the horizontal ones are the posterior parts of the rib, and these slanting ones are the anterior part of the rib. That is a little shadow that you can see through the film. Okay, so you have to always identify the first rib and then count downwards. Then you can see these vertebral bodies, see the alignment of these vertebral bodies, see if the spinous processes are equidistant, or you can say like they're aligned. See the difference between the clavicular heads from the spinous process of the vertebrae if it is equidistant. so you can rule out scoliosis as well. Also, what you can see is scapulae. This is the scapular shadow, and this is the scapular shadow. Okay, so in this imaging, we see that these are the thoracic vertebrae, and these are the ribs. Okay, so when you're looking at the chest x-ray, always see the patient details. You have to see what is the name of the patient and what was the date on the film. Then you see if there are any previous chest x-rays um, available for comparison, because when the patient have previous chest x-rays, they are mostly stored, and when you have access to them, you can compare to the x-rays if there were any abnormalities in the previous x-rays as well, and it is consistent or is it new. Then you can see the technical quality of the film. You can scan. The first step is to scan the film, see if there is any abnormality you see, and never ever stop on one abnormality. Always, you know determine if there is any other, scan through the whole chest x-ray. Then you have to describe that abnormality, see where it is located, if it is located in the lung region, in the pleura, in the chest wall. Describe the abnormality, if that abnormality is too white, if it is too black, too large, or in the wrong place. And this is all for a clinician. Always, the clinicians should always compare their findings with the radiologist report, because they are obviously experts. So first of all, we would talk about the technical qualities. So there are 5 categories that we have to see if the chest x-ray film is right. First, we have to see the projection, the orientation, the rotation, the penetration, and the degree of inspiration. So first is our projection. So yeah. Projection means that the direction of the chest x-ray beam in relation to the patient. So there can be 2 projections. One can be AP, that is anterior-posterior, and the other is posterior-anterior. The posterior-anterior one is more common. The AP films are actually labeled by the radiographer, because if it is not, it is considered a PA film. And film should be labeled supine and direct as well, because AP film can be taken in supine position and direct position, and it changes the way the film is. Also, you can see the difference that in this AP film there is a shadow of scapulae that is projected on the lung. Okay, here as well. So in both of these AP chest x-rays, there is a scapular shadow that comes and can be misinterpreted as a consolidation. Here, this is an AP shadow. There is AP film. There is no chest x-ray shadow here, but there is a scapular shadow in this chest x-ray film. This is an anterior-posterior one. Then we see the orientation of the film. So the orientation of the film is actually the left and right markings, and dextrocardia is always a possibility. Then there is the rotation of the film. So to see the rotation, you have to identify the median ends of each clavicle. So this is the median end, and this is the median end, this and this. And then we have to pick one of the vertebral spinous processes, any one, this or this, and see if it is equidistant. If it is not equidistant on both sides from the medial head, then there may be any issue such as scoliosis. Okay, so here you can see a chest x-ray of scoliosis patient, and it is not equidistant, as you can say, because it is more convex to the left and this side is more convex to the right. So it is more the distance here is going to be more than here. Then there is penetration. So when looking at the penetration of the film, we always see at the lower border of the cardiac shadow. And if we see the vertebral bodies, then you have to see if it is underexposed or underpenetrated, or overexposed or overpenetrated. So if these vertebral bodies are too clearly visible, it is overpenetrated, like this. And if they are not visible at all, they are underpenetrated. And they may appear falsely white. The last thing about quality is the degree of inspiration. You always have to take a chest x-ray in deep inspiration. So you count the number of ribs above the diaphragm here, and then you have to count it till, so this right hemidiaphragm midpoint should be between the fifth and the seventh rib anteriorly, because if it is not in the right inspiration, the heart can appear large. There can be basal shadows, which can be confused with consolidations or pneumonia, and the trachea can be a little bit deviated as well. Thank you.